Pediatric endocrine dysfunction. Sandra Monk. The endocrine system can be very complicated, and you may remember a lot of this from med-surg. So I'm just going to go over some things that are specific to pediatric and just a little refresher about the endocrine system. The pituitary gland secretes many hormones, some which control other glands that we will look at. And the parathyroid, for example, produces hormones that regulate calcium levels to the blood. And also the thyroid gland produces hormones that control the rate at which the body uses energy and promotes normal growth to the brain, bones, and muscles. And then there's the thymus gland that is plays a major role in immunity. Actually produces T cells, which is, and it's large as a child, but then decreases with age, which is why vaccines are actually given earlier rather than later, because of the production of T cells and immunity that can happen better at a younger age. And then there is the pancreas, which you remember from diabetes mellitus with med-surg. It's an organ that contains special cells, islet cells, that produce hormones that regulates blood sugar levels. And then the adrenal glands that produce hormones that help the body to respond to stress and danger. Then you have secondary sex hormones. In females, there's the ovaries, which produces hormones used in reproduction, and in males, the testes that produce hormones involved with reproduction. The pituitary gland is located at a point right behind the optic nerve, and then where it crosses, called the chiasma. And an enlarged pituitary gland could actually cause visual disturbances or even blindness in a child. So if a child had something suddenly, or gradual onset of something like that, then they might that might be something that they would look at a little bit further upon a CT or an MRI. Pituitary gland hormones. The pituitary gland is actually divided into two sections. There's the anterior pituitary, the adeno hypophysis, and it secretes thyroid stimulating hormone, the ACTH, or adenocorticotropic hormones, and then luteinizing hormone, follicle stimulating hormone, growth hormone, and prolactin. And then the posterior pituitary is the neurohypophysis, and it secretes oxytocin and vasopressin, or ADH. Disorders of the pituitary function, the causes can either be organic, or there's some specific cause, a tumor, an infection, or it can be idiopathic. It just happens and they're not really sure why. And some of the clinical manifestations will depend upon which hormone is involved. And it may result in hormone overproduction or in deficiency. And we'll talk about some of those specifically. Your growth hormone deficiency, and this sometimes runs in families. If there's a family history of small stature, or giantism, or and so they may check the child's growth hormone based on what their level of growth is. They can also look at radiographic studies and look at the epiphyseal ends of the bones and see where they're at with their growth. Is this something that's normal growth or abnormal growth? And then of course do endocrine studies to actually look at the growth hormone. There's something called constitutional growth delay, which refers to delayed linear growth, and this is growth that is behind the age mates. And so this is like a small kid in the classroom, or the preschool. And sometimes you just need to look at the families. There's sometimes families they're not average size people. They're just smaller in stature, more petite as women, and just smaller in stature as men. Hypopituitarism, clinical manifestations are listed in box 52-1 in the book. And maybe a short stature or growth decline. The height is usually retarded more than the weight. And they appear to be well nourished, and the skeletal proportions are normal. And a diagnosis will depend upon absent or subnormal reserves of the growth hormone. subnormal lab values. Management of growth hormone deficiency, it is therapeutic. If there's a tumor, then surgical removal would be required, and then growth hormone replacement also can be administered. And this is one of the this is just a tip about giving medicine with children, but growth hormone itself is best administered at bedtime because it can work while the child is resting, when growth can occur at a better rate. And also, this is good to remind kids that they take a medicine at bedtime every night, and for them to remind their parents if they forget, because parents get busy. And so I always recommend that you teach the kids, and also it gives them a sense of self-efficacy. So this is something they need to be taking. It gives them control over their disease process, and helps them to feel more confident and about that they're going to get better, and that things are going to change for them. Pituitary hyperfunction, if they have excessive growth hormone before the closure of the epiphyseal shafts, it can result in an overgrowth of the long bones, which causes vertical growth, and so also called giantism. And the child can reach heights of 8 feet or more, not as a child, but probably as an adolescent. And the vertical growth also increase plus muscle. So, and the weight is generally proportional to height. So they could be a very large person. So generally, if like a young child, 11 or 12-year-old, is getting almost adult height, then the pediatrician definitely would look into this, and they might do some both genetic and also some do some general labs and so forth to see if this is normal within this family. If this is if the child is really going to reach very large heights, which most people do not want to be over above average. Pituitary hyperfunction or acromegaly, this is excessive growth hormone after the closure of the epiphyseal shafts, and it's called acromegaly, and it's caused by transverse growth. And typical facial features is like a very square looking facial features, and it's caused by an overgrowth of the head. There might be a protruding forehead to some degree, and this is all on a spectrum. So it may just be a little bit, or it could be quite pronounced. It can cause an overgrowth of the lips, the tongue, the jaw, and the nose, and then nasal and mastoid sinuses, and also a malocclusion of the teeth and the enlarged jaw. And actually, Abraham Lincoln had acromegaly. Diagnosis, endocrine studies to look and see if there are increased levels of growth hormone, and also radiographic studies to see if there's an overgrowth of the bone. Therapeutic, it might require surgical treatment or radioactive implants as a hormone replacement. As far as nursing, early identification and treatment, and then we want to support and assist with body image, because children do not like to look different from their peers, and so this is something that the family, and it also runs in families, and so sometimes there's some families, if something is different about their children and it runs the family's genetic, then there's a lot of guilt and self-blame and that sort, so they will definitely need support. Precocious puberty is defined as sexual development before age 9 in boys and before age 8 in girls, and it occurs most frequently in girls, and some potential causes is a disorder of the secondary sex hormones, the gonads, the adrenal glands, or a hypothalamic pituitary gonadal axis. And about 95% of the cases have no cause at all. The child is just, they're developing, breast tissue, pubic hair, those sort of things at a very young age, which is, distressing to the child and, also to the parents. Oh, one other thing I'll say about that is, these are still children, and so chronologically they're still an 8-year-old girl or a 9-year-old boy. So they should not be treated as older children. They should be encouraged to dress as their age appropriate peers do, and that they still are a child. The expectation should not be greater for them because they appear older as well. So just something to remind parents and to just kind of bring up. Therapeutic management of precocious puberty, treatment of a specific cause if known, if there is some type of tumor or some other disease process. And treatment would be with leuprolide or Lupron depot, and it slows prepubertal growth to normal rates. And then, of course, they'll need to come off of it, when they get to the normal age for puberty, around ages, 12, 13. And the psychological support for the child and the family, as I just mentioned. Diabetes insipidus, also called neurogenic diabetic insipidus, and the principal disorder of the posterior pituitary, and it results from an undersecretion of an antidiuretic hormone, and it produces uncontrolled diuresis. And the primary causes are that it can be familial, genetic, or it can just be idiopathic. They don't know really what causes it. It can definitely be secondary to central nervous system infections, bacterial infections, meningitis, or trauma or tumors. Diabetic insipidus, clinical manifestations, the cardinal signs are polyuria and polydipsia. And the first sign is often bedwetting or enuresis. The child maybe has not been bedwetting, or a child that is a bedwetter. It might be something that's worth, checking out. And with infants, there's irritability relieved only with feedings of water, but not milk. And you'll notice that they're also dehydrated. They may have sunken fontanelles. And the education is that, the parents need to understand you can't give insulin and fix this, that, there's diabetes insipidus and there's diabetes mellitus. This will require something else. So, helpful neighbors and helpful family members, may be telling the family that they need something else. But what they do need is a replacement of vasopressin. And the drug of choice is a DDD-AVP or desmopressin. And this comes in a nasal spray. If it is an acute phase, they might receive it IV administration. And it requires treatment for life. Syndrome of inappropriate antidiuretic hormone, SIADH, and this results from an oversecretion of the posterior pituitary and cause of increased ADH. Kidneys are unable to reabsorb water, which is going to result in a large amount of fluid retention. The treatment is ADH antagonizing medication, and the symptoms will disappear when the ADH is decreased. And a medication that they would probably receive for this might be the Vaprisol, VAPRISOL, or Conivaptan, CONVAPTAN. So just something to remember, two medications. Disorders of the thyroid function. The thyroid hormone regulates basal metabolic rate, and so there are two types of hormones, thyroid hormone, and then the calcitonin, which affects blood calcium levels and promotes bone calcium deposition. This can result in hypothyroidism or hyperthyroidism, and the causes are congenital or acquired, and the treatment is thyroxine therapy. So both the thyroid and the parathyroid control calcium levels in the blood. Clinical manifestations of juvenile hypothyroidism. If they have hypothyroidism, they're going to be very sluggish. They may have mental decline, constipation, sleepiness. They may have myxedematous skin changes, which, as you remember from Med-Surg, are dry skin, thinning hair, puffiness around the eyes. And the treatment for this is going to be the thyroid hormone replacement. And we're going to I'll talk about hyperthyroidism in a few slides. A goiter is hypertrophy of the thyroid gland, so you might want to remember that. Often caused by deficiency of a dietary iodine, and can be easily prevented. Congenital in newborns, sometimes if the mom has been taking anti-thyroid medications during pregnancy, and sometimes it is necessary because people can have such bad side effects when they come off of their anti-thyroid medication. So they may take it during pregnancy based on what their physician tells them, and the child could be born with a goiter. It also could be acquired like a neoplasm or some type of inflammatory disease. Something to remember about a goiter with newborns or with a small infant, a neonate. Like soon after, if they're born with one or they have a goiter, then and we had them in our care, we would make sure they always had a trach tray at the bedside because it could become obstructive to the airway. Lymphocytic thyroiditis or Hashimoto's disease. This is a juvenile autoimmune thyroiditis, and it causes an enlarged thyroid gland, and the thyroid gland is going to feel generally symmetric, firm, non-tender, and freely movable. If it is not movable, it might indicate that another type of neoplasm or something else is there. It can cause tracheal compression, and as I said, with a neonate in particular, or with small infants, the child would feel a sense of fullness, hoarseness, or dysphagia. And oral thyroid hormones often decrease a goiter significantly. Hyperthyroidism or Graves' disease, there's not really a specific etiology, but they believe that it's caused by an autoimmune response to the thyroid stimulating hormone receptors. It can cause an enlarged thyroid gland and exophthalmos, as you remember from med-surg, or eyes that appear to be bulging. It can cause the child to be very hyperactive and irritable, in constant movement. These are the kids that are not sitting still in the class. It's not real common in children, but it's certainly something that might be a differential diagnosis that they might rule out in a kid that in the classroom has a very short attention span. They're having tremors, they're not sleeping at night, and then they also have emotional lability. So kids crying or laughing or cutting up in the classroom. Then this definitely might be something that would become the eventual diagnosis. Thyrotoxicosis or thyroid crisis or a thyroid storm is the same as it is in an adult. With the acute onset, there's irritability, restlessness, hyperthermia, and hypertension. With hypothermia, it's the same with children. They may have a real insensitivity to cold. This is when a child's going to be hot, and they're going to occur from a sudden release of the hormone. And it's kind of unusual in children, but if it is, it's very life-threatening. So it needs to be, this child will be in the hospital until this can get, they can get this regulated. And it can be precipitated by an infection or by surgery or by discontinuation of the antithyroid therapy if the family just decides the child doesn't need it anymore, or they lose insurance. A lot of different things can happen why people, appear to be non-compliant with medications, and sometimes it's things beyond their control. Treatment of the thyroid storm is the antithyroid drugs and propranolol for the thyroid storm. A medication that would be specific to Graves' disease. You want to remember this. It is PTU, or propylthiouracil, or Tapazole. You've probably heard it called Tapazole. And this can affect the child's white blood cell count. They can have leukopenia, and so if a child were to be having a fever and a sore throat, it definitely needs to be checked out, and they need to have labs drawn. So it's not like a little virus that they can get over if the child's is taking thyroid medication. It needs to be checked out. Hyperthyroidism, Graves' disease management therapy is controversial, but the goal of the therapy is to retard the rate of the hormone secretion, and so antithyroid drugs, the PTU, and subtotal thyroidectomy, and also sometimes they may have a partial removal of the thyroid, or they may do some ablation with radiation. Or radioiodine implants or treatments. Disorders of the parathyroid function. The parathyroid gland secretes the parathyroid hormone, or PTH, and this is to help our body to maintain serum calcium. It also promotes calcium absorption in the GI tract. If a child has hypoparathyroidism, it may result in a deficiency, and they will have muscle cramps, numbness, dry scaly skin, brittle nails, thin nails. They may have tetany or seizures. So this might be, child has new onset of seizures and some of these other types of symptoms that may be the cause. The child would have positive checks in Trousseau's signs. And management is normal serum calcium and phosphate levels. We would be checking to see where they were at with those, and the treatment would be in an acute phase, the calcium gluconate IV. Hyperparathyroidism usually primarily caused by adenoma of the gland, and secondary is chronic renal disease. So a lot of renal patients will have hyperparathyroidism and congenital anomalies also of the urinary tract. And the very common factor is hypercalcemia. And then the clinical manifestations are in the book. It's very rare in children, and the treatment is going to depend upon the cause. Adrenal disorders of the adrenal function. The adrenal cortex secretes three groups of steroids: glucocorticosteroids, or cortisol and cortisterone, or mineralocorticosteroids like aldosterone, sex steroids such as androgens, estrogens, and progestins. And this can cause altered levels of these produce various dysfunctions. And as we know, you remember from med-surg, the adrenals are located on top of the kidneys. The adrenal medulla secretes catecholamines, epinephrine, or norepinephrine. And then catecholamine secreting tumors are a primary cause of adrenal medullary hyperfunction. So usually there's some type of tumor involved. Acute adrenal crisis, etiologic factors for that are infections or abrupt withdrawal of cortisone. We know that we usually step people down or taper them off of steroids, and the failure to do that will increase in cortisone during times of failure to increase in cortisone during times of stress. And the diagnosis is usually based on clinical symptoms, if they're having an adrenal crisis or not. Some of those clinical symptoms, what they may look like, are increased irritability, headache, abdominal pain, nausea and vomiting, high fever, hyperpyrexia, cyanosis, and seizures, and then therapeutic management, cortisol, fluids, glucose solutions, and antibiotics. And I actually had a child at camp at the end of the week of camp. She had a very stressful week, probably didn't get any sleep at night, and so on and so forth. And we were able to get her to but she was having all of these, a lot of vomiting, and just really irritable, and so it is pretty uncommon, but I have at least seen it. Okay, chronic adrenocortical insufficiency, or Addison's disease, is also very rare in children, but when it does occur, it's usually a result of a tumor, a neoplasm, or a lesion of the adrenal glands, although there may not be a reason for it. Symptoms occur gradually after 90% of the adrenal tissue is non-functional. So the disease process is pretty far progressed by the time it's found in either children or adults. Cushing syndrome, and you have heard of this related to the use of steroids, which creates excessive circulating free cortisol or excessive prolonged steroid therapy. And the abrupt withdrawal of steroids may also precipitate acute adrenal insufficiency. What the child would look like: they would have excessive hair growth, a moon face, weight gain, pendulous abdomen with red striae, poor wound healing, susceptibility to infection. And the condition is reversible once steroids are discontinued, so it's only a temporary thing, and that's what a child or an adult might look like that has Cushing syndrome. Congenital adrenal hyperplasia, or CAH, and this is caused by an overproduction of adrenal androgens, which result in a virilization of the female fetus and causes the child to be born with ambiguous genitalia. And the management is sex assignment surgery. It's usually suggested that they choose whether the child will be a male or female before they go home. because that helps with confusion later down the road, with curious neighbors and relatives and so forth, that some parents will refuse to have the surgery, and then the child has to live with the problem of ambiguous genitalia that's not properly developed to either male or female genitalia. And then sex assignment surgery, and then cortisone replacement. Pheochromocytoma, you may remember this from either watching House or from MedSurg. It is an adrenal tumor that secretes catecholamines, and the symptoms mimic hyperthyroidism. So there's a lot, there's irritability, there's rapid heart rate, and then also diabetes mellitus. And the management is the surgical removal of the tumor. Therapy also includes glucocorticoids or mineralocorticoids. And a nursing alert is you do not palpate the abdomen of a person that has been suspected or diagnosed with a pheochromocytoma. Disorders of the pancreatic hormone secretion. This is, I'm going to mention a few things that are specific to pediatrics as far as diabetes is concerned. It is a total or partial deficiency of insulin. It is the most common endocrine disorder in children. Usually it's diabetes type 1, but we're seeing more and more diabetes type 2 in children. If the child does have diabetic ketoacidosis, DKA, very elevated blood glucose, this is considered a pediatric emergency, and this child will be treated in the ICU setting. Diabetes type 1, characteristic by the destruction of beta cells, usually leading to absolute insulin deficiency. Typical onset with children and adolescents, usually not with younger children, but some younger kids do get diagnosed with diabetes. And most is type 1, and it's more prominent in Caucasians. Type 1 is. Now type 2 arises because of insulin resistance, and usually after age 40, but with childhood obesity being on the rise in childhood and early adult and adolescent and child, we're seeing more and more in younger people. Certain populations, such as Native Americans, people who have Hispanic origin, African American children, are more at an increased risk for type 2 diabetes. It's genetically determined, and it affects people, and they may require the affected people may require insulin injections as well as oral, anti-diabetic agents. Okay, long-term complications, nephropathy and retinopathy are a consideration with children who have type 1 diabetes. So they are going to need to be having BUN and creatinines checked, as well as good vision treatment, monitoring them for any complications. Neuropathy is also could be indicated after even 5 years of having diabetes. So even a child that is in their adolescence, if they were diagnosed as a younger child. One cardinal sign is poor wound healing, particularly like adolescents that have acne that may be a little slower to heal than with other adolescents. Therapeutic management of type 1 diabetes mellitus, of course, insulin therapy with type 1, and they're going to need to be doing routine glucose monitoring. Children, even an 8 or 9-year-old, can be taught to do their own injections and their own blood glucose monitoring, and that's something you can watch them do and see how they do it in the hospital. And I've seen more than one kid who just refuses to do it, and it's real important, as I said earlier, talking about the growth hormone, that children get a sense of self-efficacy, and that this is something that they can take care of. And the rest, it's just going to give them more confidence to develop emotionally, and also have better compliance with their medical regimen. They want to have a goal blood glucose of normal levels of 126 or below milligrams per deciliter. Their hemoglobin A1C should be below 7. We know normal is between 4 and 6, but if we have a diabetic, we want to keep them below 7. And with they may recommend, if they're like floating above 7, that they'll do an insulin pump rather than insulin injections. Exercise and nutrition is really huge. They need to have a diabetic educator that works works with them in addition, to nurses, somebody who really has expertise in working with children who have diabetes. A couple of considerations with children is that they're growing, of course, but also their exercise varies. So if a child has been inside all winter and all of a sudden summer comes and they're a lot more active, just need to remember they can exercise. They just need, and it's good for them, just need to remember that they need to have a snack before they exercise. If they start a new sports program, then they need to be reminded to take, before they exercise, they might need to take a snack, and they're giving some extra snacks to their teachers and to their coaches and those sort of things, or anybody who might be providing child care. So the patient and the child needs to know how to manage the disease process, and also how to manage hypoglycemic episodes, which includes, and this is an important concept, it includes that if the child take some sugar cubes, or if they have glucose tablets because of low blood sugar, and what those signs and symptoms would look like, then they need to follow immediately with a complex carbohydrate and then a protein, and they need to know what 15-gram carbohydrate is. It's not a Twinkie or a donut. It's something more substantial than that. And so those can be described in nutrition with the diabetic educator. The family be given a list of what is actually 15 grams snack. They need to know what to do on sick days, just like adults do. Whether to continue to take their insulin, or if they need to call and get a dose from their physician, or what to do with the insulin pump. If the child is not unable to eat because they're vomiting. And then management of DKA, which I said is a medical emergency because it is with pediatrics. Patient education, insulin therapy, they need to understand about the duration, the onset, the peak action, and what happens with the insulin pump therapy. Children can do their own glucose monitoring, and it's just not anything that is a casual thing. It is something that needs to be done every day, and they need to be able to recognize and treat both hypoglycemic and hyperglycemic events, and then how to manage sick days. Hygiene is big with kids because kids are not always want to be the cleanest, and so they have to have really good hygiene, and reminded to take care of their teeth, brush their teeth, as well as take care of shoes, and not walking barefoot, and those things that kids tend to do. And also the family may need a lot of support too, as well as a child, particularly with new onset diagnoses. And if this is a familial thing, as I think I mentioned earlier, that can also cause sometimes some guilt and regret, if the child has diabetes, as well as other family members. And that's the end of the presentation.